There's been a lot of research for these biomarkers for over 20 years now. And we're just getting to the point where we know what the utility may be of them. And essentially, if you boil it down bare bones, those biomarkers are going to help us determine who is most at risk for the adverse outcomes associated with preeclampsia. So they can help us prevent it, but they can help us identify individuals who need to be hospitalized versus those who don't need to be hospitalized, right? Which helps control cost, and also helps to prevent unnecessary early deliveries, which is a problem with the hypertensive disorders of pregnancy. And the negative predictive value is very good because it gives you a nice long window, right? That says if they test negative, then you know that probably for the next 4 weeks, they're in a safe zone, right? Where if they test positive, you know that in the next 2 weeks, they're 1 to 2 weeks, they're more likely to develop the disease and need to be, more closely followed. Maybe those are the patients who need to be hospitalized, or those are the patients who need to be, moving toward delivery. That's a great question. So, hypertensive disorders of pregnancy are a whole spectrum, right? And there are women who begin pregnancy that are already hypertensive, and it makes it very difficult to determine when they've crossed from just their chronic hypertension into a preeclamptic episode, right? These biomarkers help with better certainty determine that, because the traditional lab work that we do in concert with blood pressure and proteinuria that we use has not always been as reliable as it should be. These biomarkers help us to identify the women who we know already have placental damage from very early in the pregnancy when the placenta was establishing itself, right? So, long story short, they have damage to the blood vessels. Those blood vessels are leaking these proteins, and to date, we have not been able to measure those proteins, but now we can. And the other stuff can be abnormal for a lot of reasons, not just because of preeclampsia. That's a great question. So I think the timing, so 24 to 34 weeks is the target audience right now, because that's where we can have the best impact, right? Prior to 24 weeks, unfortunately, the chance of survival for a baby probably not as good. So we wouldn't want to intervene then if we absolutely did not have to, right? And above 34 weeks, their survival is great. So if we have to intervene, no harm, no foul, right? It's that in between time when we need to either say, Mom, you're good, like, don't worry, or Mom, we need to start focusing and preparing you for delivery. But I think the biggest impact it's going to have, honestly, is it's going to help control some of the costs, so we can start to weed out unnecessary lengthy hospitalizations that are a strain, right, on the healthcare dollar. And we can actually hospitalize and focus the ones that test positive, so we know they're most at risk, right? And it'll help to prevent babies being born early unnecessarily, which then drives up the cost of the care for them and all the risks that go along with a baby being born before it's supposed to be born, right?